right? So with all of the technology that we have, we know that there is potentially ways of testing the blood to find out how much cancer cells may still be around after you've maybe gone through a surgery with Dr. Antonoff and had, all of your cancer removed. Could there be still some microscopic cancer cells that might have been left behind? And this is that minimal residual disease concept that, they've been looking into and they've been testing. And, it hasn't become something that is definitely FDA approved, but I think it's something that we're going to have to look out for because I think it is going to hopefully be something that's helpful to our patients in the future. We also have circulating tumor DNA where we again do a blood draw and look for tumor DNA that might be able to help us predict, is this patient going to have an early recurrence of their cancer? There's several different targets and new emerging biomarkers that are there. There are things that we've already found from KRAS, but there's new KRAS mutations that we're looking at, newer variants of EGFR and HER2. But then there's other things that we haven't been able to target that are all in clinical trial, looking at TP53, MTAP deletion, SMARCA4, FGFR, sorry, Nectin-4, integrin B6, and the folate receptor alpha, and many more. I mean, there's just so many for us to be able to put onto one slide. It's kind of difficult. But then there's also technologies that are looking at, gene expression signatures to say that is there a specific thing that we can find out from the way that this gene is expressing proteins to help us understand, is it more likely to come back? Is it more likely to move on to other organs? What does that mean? We've also been looking at the microbiome markers. So all of us have normal gut bacteria, and they're looking at this gut bacteria, and does it show us why some people may be responding to immunotherapy better, and does it affect our responses to immunotherapy? They're looking at genetic variations in patients like their HLA type, and their immune fitness to say that if you have a specific HLA type, are you more likely to respond to an immunotherapy? And then, we can't forget about AI. It's been, front and center for most of us, and we've been hearing so much about it. But they're also looking at AI-based response predictors. Can we use a lot of our data, whether it be clinical and our biomarkers, and putting everything together and use that to help us determine, are patients more likely going to respond to one therapy versus another? So, when is the right time to test for biomarkers? And I think that's a very key and important thing because at the time of diagnosis, before we start treatment, is probably one of the most important moments for us to check for a biomarker because this is going to help make sure that we choose the correct treatment option at the beginning. Now, if at some point, unfortunately, our treatments stop working because we know that that can happen and our cancer can outsmart our medications, and we do have progression of our cancer, which means that the cancer either grows or it returns. The cancer can change over time, and repeating the biomarker testing at that moment may be helpful because it might give us other new options that we didn't know were options previously. And then after surgery for certain types of cancers, it may be important to check biomarkers as well. Now, after surgery for certain types of cancers, it's not always standard of care, but it can be done also through clinical trials. And this can help us potentially guide whether a patient needs extra treatment or adjuvantly after their surgery. So, kind of moving to the other side of the biomarkers and looking at the immune biomarkers, PD-L1. PD-L1 is a protein that you can find on your cancer cells and some of your immune cells. And I want you to think of it as a little shield or a break that is on the cancer cells, and it hides it from your immune system. Okay, so knowing what a PD-L1 level is can potentially help us when we are looking at treatment options. So how do we use a PD-L1 level, right? So PD-L1 testing helps us say, is this patient going to be able to respond to immunotherapy? And what it does is immunotherapy, in a very simplistic way, works by releasing the immune system's brakes off of the cancer cells. So your immune system, which will naturally detect anything abnormal in your body to get rid of it, right? Like when you get sick and you get exposed to bacteria or a virus, your immune system activates and says, oh, this thing does not belong in my body. We need to activate the immune system to get rid of it. So if we use our immune system in a similar way, it can allow the immune system to recognize that cancer cell, attack it, and try to get rid of it. So PD-L1 testing can help us determine, one, is immunotherapy an option for you? And two, should immunotherapy be given alone or should it be given in combination with chemotherapy? And so it helps us guide a lot of our treatment choices in the event that we don't find a biomarker that we can target outside of that. And so, how do we test for PD-L1, right? So again, that tumor tissue sample, either from a biopsy or from your surgery, is sitting somewhere in a lab, and that can be sent out for testing or can be done locally at your lab, where the pathologist will take a stain and apply it to the tumor and look at it under the microscope to determine how many of these cells are testing positive for PD-L1. Now, how do we interpret this? So, most of the time, you're going to get a result back that gives you a percentage. So, there's been some categories that have been made that, if it is, less than 1% or 0%, 1 to 49% or greater than 50%. And right here on the right-hand side, you can see the tumor tissues, and on the bottom, you see the PD-L1 staining where it was less than 1%. You don't really see much brown there. And then between the 1 to 49, you kind of start seeing some brown. But when it was greater than 50%, it was quite obvious that there was a significant amount of brown there, which was your PD-L1 that was testing positive for that protein. And so, in general, we believe that the higher the PD-L1 level, immunotherapy is more likely to help. And we believe that if it was lower or negative, it may still work, but it might need some combination with chemotherapy. The important thing to remember is PD-L1 is not the best biomarker. We're looking for more biomarkers to help us determine how immunotherapy works and how we can better gauge people's responses to it. However, it's a guide and it's not a guarantee. And I want to be very clear about that because there are going to be people that have a lower PD-L1 level that got immunotherapy that still have an amazing response in comparison to somebody who had, a different level. So, why do we sometimes have to repeat that biomarker testing? Over time, sometimes our cancer can evolve. It can develop new mutations. It can develop resistance mutations where, your cancer has outsmarted those drugs. And, maybe sometimes your previous treatments over time, causes changes in the biology of your tumor. There's new therapies that become available all the time. We see new drug approvals and things that have been in clinical trials that come, to the mainstream, which is always exciting. When you first got your first test, it may not have been a complete test or it might have failed the first time because we didn't have an adequate sample. And, repeating the test helps us ensure that when it comes time to discuss treatment options, we have all of our options on the table.